So hi, I'm Ed Levin, Director of the Duke Center on Addiction and Behavior Change, part of DIBS, and welcome to our seminar series. And as you can see on the screen, there's our listing of the Spring 2022 seminar series, and we're getting into the midst of it. Before today, I introduce today's speaker, I just want to look ahead a little bit. So coming up is our kind of big event of the semester. It's our symposium, a day-long symposium together with for resilient youth. Impact of risk prevention. So please register for that. You can go to the DIBS site and the CABC page, and the listings on there, and maybe Tyler can put it in the chat as well. It's free, but we do like to keep track of all the people who will be attending that. And then just looking further ahead, we're going to continue on March 2nd with Linda Perino from our sister institution, Wake Forest, over in the Triad. We'll be talking about her work with chronic drug use research, and then Byron Jones from Tennessee. And then Reggie Kennedy, who's a former student of mine from NCA&T, will be coming through. And I'm finishing off with Emily Rissman from NC State. And then we'll have a joint seminar with the Duke Center study of adolescent risk and resilience with Nisha Godfreyson. Anyway, now it's my pleasure to introduce today's speaker, Dr. Paolo Mannelli, who is Associate Professor of Psychiatry and Behavioral Sciences here in the Duke University Medical Center. Has been here since 2004. He earned his MD at Catholic University of Sacred Heart in Rome, and did his residency there as well, and a fellowship in psychiatry and addictions at University of California, San Francisco. And today he's going to speak to us about from bench to bedside to computer screen. Paolo.
You can see that, right?
Yeah.
So what we're going to do today is try to navigate some of the changes induced by COVID in translational and clinical addiction research, discuss problems, and identify possible future directions of virtual research, because it looks like it's here to stay, although he has presented some problems. Now, the disclosure. I've had research funding and consulting from several pharma companies that have been involved with medication and treatment of substance use disorders. So we are behind the computer or on the phone to protect ourselves and others from COVID. But what has been COVID doing for addiction, or to addiction, I should say? If you look at in general, the disaster research, psychological and disorder and substance abuse increases in the aftermath of both man-made and natural disaster. I looked at the last one, a last big one, with a significant commotion and post Katrina, New Orleans, and after 6 months there was an increase of 30% hospitalizations for substance use disorders, which was an indirect measure of severity of the condition. And we are 1 year after the beginning of COVID. There was the first pit stop for evaluation, a 30% increase in substance use disorder overdose deaths. The two numbers are, of course, totally casually similar, but do indicate a severity of condition that sometimes drags on, and probably for us, it means it's going to drag on even more, given the duration of the problem. If Katrina was able to induce in such a short time such a big change, we can imagine that the chronic problems related to COVID are going to be probably staying with us for a little longer. What COVID has done is translate everything in remote treatment. Telemedicine for substance use disorder, what does that mean? Or has meant and is meaning to us in the treatment of substance use disorder patients. The treatment guidelines have been, in general, relaxed. You can do evaluations remotely of the first-time patients, and you can have a take-home methadone much easier than it used to be. The performing UDS, urine drug screen, is much looser in terms of what is required. What is important, I think, is the centrality of patients in these new, quote-unquote, temporary environment. So it is true that we cannot trust patients too much, but more than us not trusting the patient is a patient that has to decide to step up and take some responsibility. We see that in the clinical environment. I don't know if you have experienced anything similar, but it definitely, they have to take more responsibility because we cannot monitor them so strictly. They have more hotlines for emergency, virtual community support meetings. The COVID solitude that has been sort of associated with a problem of increased use, especially for alcohol and sedative substances, is in this way somehow faced and sort of try to mediating the introduction of more contacts for the patient alone at home. These changes, some of these changes will stay there. Some of the patients are comfortable enough, not all of them. And for those who are not comfortable, probably, and these are the cons of the telemedicine in SUD, it is more difficult to have them returning to treatment, have them returning to community programs that are now opening up, but not sort of accepting a regular flow of patients. I think it is from last year, a study done by UNC on pregnant women that were accepted in the state of North Carolina by community programs before the pandemic. About 50% of the requests were answered, and now it is about half of that, 20 to 30% are answered. So that is a clear problem. For those who anyway have to go, the connection with the community is much looser. And of course, the therapeutic alliance with these people who are not doing well or cannot deal well with video, and sometimes we do have the same experience, I think. If you are a clinician and you spend time on the video, a long time on the video, at the end you have some kind of rejection reaction. That is difficult to serve them and those, of course, who are underserved. And this is going to be a leitmotif in this presentation. We have to remember how many people, because of underserved condition, do not have a video approach possible. Sometimes not even the phone approach, but the phone approach is much more difficult to develop a real kind of workable plan of treatment with these kind of patients. How COVID has affected the translational research chain, cascade. Basically, we are going now horizontal, while the typical and traditional one has been vertical. So basic research, starting from cell to animals, to humans clinical trials, to practice has been the backbone of substance use disorder. We have to remember how important it has been for the development of opioid use disorder treatment, for instance. Now it is not functioning that well in that way. It has slowed down. There is not much of a connection between the basic science and the clinical arena through the clinical trials. And it is more workable, the horizontal approach. And the horizontal approach goes from practice to bedside research, and not as much from bedside to practice, because there has been a clear slowdown of clinical trial and clinical investigations in drug addiction. Either way, the feedback loops are reduced and disrupted. It doesn't go to way anymore. It's mostly from what the practice can teach us in this emergency and what we can learn from the practice to conduct, hopefully, modified investigation that meet the requirements. Not that we didn't have before even COVID, translational challenges, the individual differences, the overinterpretation of results that did not translate in clinical workable approaches. Well, they were sort of working well in investigational environment. The exclusion of alternative explanations, because with substance use disorders, if you include alternative explanations, you don't work out anything. But if you turn it off, you basically develop treatments that don't work. And of course, the importance of a cross-species comparison within the preclinical environment and between preclinical and clinical. Now, all this has been made more difficult by the lack of feedback, the feedback loops that we were talking about before. Going back to basic from clinical now is very difficult. But we have to make an effort to keep it working or restore the work. And in general, in clinical studies, we have always experienced lack of adequate number of subjects or effects, clinical effects. Subjects are sometimes picked and selected just to demonstrate, confirm the research idea, which is a falsification that we all know pretty well. But in drug addiction, this has been probably even more clearly present due to the lack of several alternative treatment, investigational treatments. Now it's getting better, but it's still there. And of course, the leap of interpretation from laboratory to trial to clinical effects is still a clear obstacle for us. So we need to repair the translational chain of communication, and this must start from identifying new paths. In this case, I will follow the clinical research path, which is the one I know better. So when we had the issue of telemedicine as delivering treatment, this has, because of COVID, this has affected the clinical environment as well, obviously, interfering with recruitment, the informed consent process, patients' medical evaluation, the importance of clinical practice, as we said, has been more and more relevant in that way, and the challenges of analysis and interpretation of treatment results in this new environment for biomedical statisticians have been really significant. What I'd say probably the providers, of course, have to learn to use telehealth to monitor and improve treatment and retention. But in particular, the big mental change has been the clinician or researcher have been used to wait for the patient to come to them up to 2 years ago. I believe it is a long time, but now they have to go to the patient. It is a motion, an inverse motion that affects a lot of aspects of treatment as well, in terms of change a frame of mind. I'm entering someone's room, I'm entering someone's house, and this person might not want to talk to me or might not be the right time, even if it was established to meet. And before, the patient will not come. It's a no-show. Now it is more difficult, it's more intrusive, even if he can or she can decide to not respond to the call. But it's a little bit different mentally. Of course, COVID has offered a lot of new stuff to look at from the neurobiological, neuropharmacological point of view. We can now study at basic level and at translational level the interaction between COVID treatments and psychoactive substances. And this can actually drive the push for new interventions. We don't want COVID to be with us forever, but more or less epidemic, endemic, or something similar to it. The stressor of COVID or whatever is going to be instead of COVID, it's here to stay. And as we said, has probably triggered changes that are going to last beyond the presence of the virus as a real threat. What is probably among the most interesting aspects of this is what the COVID crisis can offer in terms of opportunities. Behind the crisis, there is always the opportunity, right? The back of the coin. And we can build a learning healthcare system. We can decide how best research can develop and deliver treatment as real implementation research principles suggest, without compromising the quality of the research findings. In particular, if we look at the patient's goals and needs, the health service changes could, and this depends on many factors, among them the political ones, to be decided, can change to eliminate healthcare disparities. So the approach that we have been trying to have in school, with all the computers provided to our children and being more or less successful, in some cases really not, but it is definitely better than what we have been experiencing in healthcare. So that is probably something to follow. Availability of locations where you could have, and this is beyond the virus scare, where you could have patients coming from rural areas, gathering and communicating with doctors in a feasible way for everyone. So it's interesting that looking at this subject, I've gone through, a little research of PubMed and similar, and there is a lot of stuff, a lot of people having opinions. Some of them are very good opinions, some of them are less interesting, but anyway, a stimulating environment. This is stopping basically at 2020, so probably by now we have doubled the amount of this volume of research. What is missing, of course, and is also for temporal reasons, is more theoretical and not a lot of data that we can share. Hopefully this will happen soon, because we have to build on data the future of the virtual and perhaps hybrid approach. So it's not that we were not ready in terms of theoretical approach. It is true that we have not had to apply the decentralized clinical trial approach, decentralized clinical investigation. We can more in general define it, approach to treatment. The work from pharma companies, but in this case, CTSA, NIH-funded CTSA clinical trial science awards, hubs, have been working for years to develop a point-to-point model of remote methods that could match the on-site study visit methods. And it looks kind of clearly matching, right? So when we started the expectation at the launch of remote research in a larger scale now, after theoretical designs were ready, the goal was to bridge existing studies. A lot of studies were just left in the middle of the river, and they had to be closed or hopefully completed somehow. Start new investigation. This has been less of a case up to now, as you all know, and produce data that, this is also important, could be at least comparable with previous studies data. If not, we have a turn of a page and we cannot create new science, right? So we had the telemedicine platforms already there, very useful because you can build on that remote approach. Most of the participants, of course, for the scale of the virus or for real desire of novelty and of feeling comfortable not having to go to the site, to the clinical study site, were, sort of willing to do it. A lot of survey platform was already there. We have been, in our case, at Duke, knowing very well, Red Cap, Qualtrics, Survey Monkeys, even to do meetings and whatever, anything was there. And the self-report assessment methods were already built. In addition to this, some of the study sites or study teams and investigators were using the wearable device to get physiological measures from patients already when they are going home. So everything fine. This is a CTSA results of feedback. In 2021, 60 out of 65 hubs of a CTSA network were able to give a reasonable answer through their PIs after listening and talking to staff and collecting patients' information. In other words, it is okay. There are some points that are not that easy to solve. We are not that easy to solve. They need more work. The light blue part of the bar on the right tells you which ones they are. The delivery of intervention still finding very difficult to be managed. The physiological measures, believe it or not, were not easily delivered, collected, and transferred. Laboratory sample collection was difficult, and the investigative product management, the medications, in other words, when they were present, were presenting some problems to monitor and deliver. So in general, okay, first pass, but needing more work on it. So physiological measures from the experience of a CTSA, which is very useful for us because they are the cutting edge of the clinical science, the translational science, transfer to clinical and eventually to treatment. Most of these electronic capture methods or wearable devices were not part of the original study design. Many of these were still in need of validation, and there was no time to do it. There has not been time to do it. The lack of familiarity of some patients to complete their task of access to digital portals were also a problem. And the information collected by study participants had to be manually entered for the assessment of the CRFs, the case report forms, which is time consuming. So something that should be time reducing, as in reality, as it is at the beginning of a process of a change, being more difficult. And other things were trying to go around other teams using these red caps, surveys, and emailing them to participants for completions. But we know that PHI and protection of data, that it's more difficult in that way. In some cases, non-electronic alternatives were used and recurring to the local providers assessment, which is still an exposure in terms of COVID risk, but it was found a reasonable compromise. Or the PI would take responsibility at once to skip the assessment and not do much else than the screening part of the vitals and the physiological measures. Ideally, the digital measures can, through the passage from clinical research to clinical care and public health, identify an acceleration of data collection, quality of care, and improvement the public health approach, because if anything, they are there instead of 9 to 5, like any study site or most of the study sites. They're there 24/7. So they can be used, once they're validated, they can be used properly to collect data that are continuous. Now, of course, the continuous data is a great idea, but with some of this data, we don't know what to do yet. This is like, if you remember at the beginning when we had MRI, even more than the CT scan, the MRI was producing so much information that we really didn't know what to do with it. Most of it was not usable. And that is probably also what is happening now, will happen, because it doesn't happen consistently now, with the electronic data measuring the physiological measures. But we definitely have a potential for compacting these results into meaningful clinical indications for the future. The laboratory was another problem, a problem place. So any method in the CATSA experience was adopted, basically. Going home, collect blood during home, and then bring into the study site, ship lab kits to participants, forgo labs. In reality, the virtual option for laboratory sample collections were not available in about almost half of the programs responding to the CTSA survey. Obviously, this is not imaginable as impossible to overcome. in terms of obstacles, but it is a real problems in terms of cost for the single site, cost from the single group of investigators, which brings the issue of sort of merging investigators into big groups, which was already developing, was already happening, which on one side is very good. You have a possibility of larger groups of patients to be studied. On the other side, the individual ideas and projects can be sort of suffocating in that kind of environment. Of course, one of the biggest problems was how to manage the medications. And again, this is using any kind of delivery service, research staff, or specific med speed delivery service to the home of patients. But the ability to monitor participants closely was not there because you cannot guarantee the use of medication. This could be a real problem for addiction studies, obviously in perspective. We'll get there a little later. But in any case, the possibility of going to the site in patients who are not that scared of the COVID was a relieving solution, even if temporary. So this is to pick up their medication. This is a standing problem if we want to get for the long run on a virtual side of study and treatment. So what was observed from the CTA experience is identifying strength and weaknesses. The strength, EHR, medical records, electronic medical records are probably the biggest strength. That's why the virtual approach is going to stay. There is always portals associated with the medical records that can facilitate that. The improvement has to be sort of still in theory and has to be achieved is the collection of biomarker data and the utilization of real-time data between research visits, what to do and how to do that. And this is more of a statistical and data storing issue on the larger scale. The importance of validation of devices and data security and privacy, safety, protection. This is a new frontier of how to use the PHI outside how to expose or not to expose the PHI outside the investigative clinical site. So, the hope is that the pandemic has actually accelerated this process to the point they can walk on its own legs. We are talking about the specific aspect of addiction and reviewing this information about, in general, clinical trials and the virtual clinical trials, virtual studies. At first you can imagine how difficult it can be for addiction. Then I looked at it and said, maybe we are not that behind if we want to spend some time trusting patients, trusting participants, and working with participants for a better balance in the transfer to virtual investigation. For instance, we have always second guess the validity of the self-report measures in addiction. We don't do that with depression. we have always done with addiction, since the original sin was probably the lack of treatments. So when we didn't have a treatment alternative to the one delivered that was not working, we were denying the issue of a patient. That was the easiest way to do. So you're not suffering, you're not experiencing withdrawal symptoms because it's impossible. The treatment is working. So since then, we have come a long way, but that was the method, since the 1970s. But still, the idea that patients are not that trustworthy about what they tell you has set in our mind and is affecting sometimes not only the clinical, but also the investigational aspect of treatment. We have time and again over the years identified, for instance, that subjective reports of withdrawal from opioids are more reliable than objective withdrawal reports, and they're more likely related to the risk of relapse, the treatment completion, craving, needs of other medication. So all this has been there, and we just have to trust the participants. We have to trust the voice of the patients more in this sense, in general. And the self-report use of drugs, and this is also being confirmed, not only by recent studies, as it is shown here, but by the clinical experience. In other words, there is no patient that is hiding a problem when it's behind the video. If you can work well with a patient, not talking about someone you have seen the first time, someone you have built an alliance with, can work with you to make you understand where the problem is, without necessarily having the UDS, the urine drug screen done. And if you need the urine drug screen done, you can now do it. Hair samples are becoming more and more useful, more and more reliable. There is a possibility of doing oral swab test for drug use. And this can be all captured in video while you're talking to the patients, or it can be captured in the validated apps. There is Dr. Villardaga here at Duke that is doing a very extensive work with tobacco users and with psychiatric and non-psychiatric medical complications associated. And it does work. They work. There are platforms that can follow you 24/7. And they are reliably there also to capture your medication compliance behavior. So this is what we are with drug addiction. I think it's a very promising baseline for virtual studies. I hope that we can confirm that the results of relaxed measures in terms of assignment of new guidelines, temporary guidelines for COVID, are going to show that relaxed measures don't mean more dangerous outcomes. They mean same outcomes, if not, maybe, hopefully, better outcomes. And in terms of outcomes, I would like to spend a couple minutes talking about how important it is to listen to the patients also for what they think is salient, is important, is relevant in their daily life. This is a study has reviewed 60 opioid dependence trials, looking at the type of outcome, and interview a group of methadone-maintained patients. And it is, of course, an overlap of outcomes that was found. The majority of patients agreed that abstinence for opioids was a primary goal. But there are also other underreported sort of outcomes in clinical trials that otherwise are seem to be or could be important. And this has to be replicated, of course, in larger group of patients, but it draws our attention to how important it is to listen to the patient. Yeah, total abstinence is great. It might even be a primary goal. But if I can not spend all my money on drug use, that is, a close second probably. If I can keep my job without struggling, it is as important. If I don't get sick with medical conditions related or not strictly related with drug use, that is also important. So all these factors that are not in our clinical trial reports, are not in our scientific papers, are probably in need of more attention. That is also why when we talk about clinical significance, sometimes it's very different from statistical significance. We have the statistical significance associated with outcomes that we measure, looking at the patient behavior, monitoring the patients. But the clinical significance also more closely report how comfortable are the patients with the treatment, how meaningful, how important is the treatment for the patient. So that would also respond to our need of better scientific evidence for the treatments. Of course, it's not fantastic, all fantastic, and drug addiction is ready to fly on the whim of the moment for any kind of virtual assessment. There are some treatments that will require, at the very least, even on a virtual base, at the very least, a hybrid structure, site visit and take home and virtual follow-up. When you treat withdrawal, especially opioid withdrawal, when you transition from opioid agonist to partial agonist to antagonist, that is a difficult transition and needs a closer monitoring for the safety of the patients as well. And the compliance and reliability come as a second or even third position when you have medications and use medication for drug addicts. They have no reward component. So they might be okay on that, but in the phase of introduction of a medication, they need to be helped. They need a closer look. They need closer monitoring for safety reasons. These can be managed in a kind of mixed environment of research, clinical research. And where are the pharma companies? I'm not saying that they rule the world, and they shouldn't, but it's important to understand their position. The survey here that you can find, and clicking on the link up there, is identifying few important factors. First of all, there is the intent to continue. It is important, has been collected good information. The industry is confident that the data generated are good and reliable for clinical trial approaches. And they especially think 97% the clinical trials, virtual clinical trials, decentralized clinical trials are here to stay. But then you also see that there is a lot of 50-50. Is it good information that we collect? Is it too much work that has to be done, too complex by the investigators and study staff? Is it too difficult to manage all this data as it is now? So between 30 and 50% of people in the industry involved with this DCT approach have been raising these issues. what I think is important to know, so they want to continue, of course, it looks like, and this is like the electric cars, right? They want to continue, but what is important to notice is that they want to live, and it's a great change in this sense, resonating from the clinical to the industry side. They want to allow patients to choose how to participate. You know, it's almost 60%, which is a significant portion of expert in clinical trials from the industry have stated that the patient should decide what to do, which might be Columbus egg. So the current clinical research environment has identified the possibility to convert protocols from on-site to remote. There are no alternatives, so it has to be done. The quality of the results still has to be evaluated, but at least research goes on. Multiple protocols targeting COVID were started, as we said, as a stress element in any kind of clinical trial treatments. And it is now, and it's understandable because of the kind of stress reaction to COVID, the recruitment is still below pre-COVID era, and everything is below pre-COVID era anyway. And the idea of having this between the delivery of the medications through treatment in telemedicine and the clinical trials, investigational approach, virtual investigational approach, has helped probably the population to get a little more comfortable with this kind of method. So we can envision the transition from left to right, from traditional trial, virtual trial, collected data through hybrid or total virtual data from a real site, or get rid of a site and have only the data collected remotely from central hubs. This is a little scary to me, but you know, it's just a mental thing, I guess we have to get used to. What is probably important to notice that all these three elements, even in a transition to the future, have to stay together. If not, the idea of serving the patients based on their needs is not going to be possible. And like a memento, let's remember the definition of NIH for populations with health disparity is the kind of people that we should be able to reach with healthcare approach and with through investigational approach. If we cannot reach these patients, and this should be part of every presentation at the end, like just remember that, I believe. If we cannot reach these populations, not only we have a big missing from the quality of our scientific data, but we are not really serving properly proper healthcare. And this is not political, it's just basically basic reasoning. Now, safety concern, who's enrolling, remote consenting, who's consenting, all these issues are still standing about remote research. Will need some kind of data collection to get probably dissipated or confirmed and worked on. But for now, we can only present as theoretical issues. And in any case, when we can have a wearable at home, we probably won't have the 180 over 120 blood pressure that many times the doctor sees at the office when you have the office effect on collecting physiological measures, we are going to have much better measures. We are going to be able to have, once a regimen, the possibility of having a better enrollment in research studies, and probably also a better communication with participants about the results of the study, which has been always part of the consent form, but not necessarily the first place for the researcher. All the conclusions, I don't want to repeat everything, just important to notice, I think, for the purpose of, in my opinion, of drug addiction studies, we have to decide how much of the study should continue to be randomized and double-blind and imposing a non-observational, non-naturalistic approach to study medications. That in per se, especially with addiction, is going to be a big bias. I understand we can open a discussion about it, but the validity of the results is not guaranteed only because we have always negative findings as people drop out from drug addiction studies because they were forced and randomized to a treatment they were not familiar with or didn't want to begin with. And we see, and I notice here, that more and more there are studies that look at the post-study a naturalistic approach, which is funny enough because if we start looking and see how they are doing 6 months after the study conclusion, well, let's start having studies that see and look how they're doing during the treatment once they pick up their own treatment. Don't want to get rid of the randomized studies, but just to complete in a better way. I think we can stop here. We're still, right?
Yep. No, thank you. That was wonderful. And I appreciate this dose of reality in drug abuse studies. And so we have some time to discuss. I just want to lead it off with, you showed there's a great reservoir of clinical wisdom that I think we're not taking advantage of. So in addition to, providing verification that a treatment works or doesn't work, or implementation science in terms of all of the details that need to be attended to in terms of having something be effective clinically or not, I think that there is a lot of information that could be a hypothesis generating that can go from the clinician back to the basic and translational scientists. So I just wonder how we can facilitate that.
That is being, I think, the strength of research in this country, right? So has been always a backbone of research. I agree with that. And I am concerned at least a little bit about the conglomeration of study groups. Having large study groups prevents that from becoming reality, what you're saying. So yes, it is important to have valid results, effective results, reliable results, to have big study groups, but the individual observation and the going back from the individual observation to the translational approach is, in my experience, being a little bit cornered lately and should be given more importance. I agree.
Yeah, thank you. So I just want to open it up. Other people want to make comments or questions?
I have a couple of questions. That was very thorough, and I really loved the insight into the whole process, Paolo. My first, I guess this is a comment. You've explained to me what I see in the literature, which is people doing studies using measures they can make. And to me, the downside of it is it's not moving the world forward. I mean, how many heart rates do you need from people who are getting a treatment that isn't going to affect cardiovascular function. But I get it published immediately because it's all that they can do. But you pointed out some good rationales about that. But the other thing I was thinking about, because I, of course, think in terms of the value of things that go beyond, measures that go beyond my Apple Watch monitoring me 24/7. And there could be real value to that if you correlated it, for example, with your withdrawal effects. You can generate actually some cool data. But, you know, I can get anything I need from Amazon in 48 hours, pretty much. And it's astonishing, the transportation network that can exist. And I think that, and this is where you wouldn't even have to have common studies, but just like Amazon sends packages to a lot of different customers, you could generate local transportation networks that would allow you to generate some of the biologic data that is being lost because of really nobody tackling that particular element of it. And it's none of it's that esoteric. It really isn't. You know, my doctor didn't want me to come in for a colonoscopy, so she sent me this thing that I sampled my stool with. You see it advertised on TV all the time now. You know, that can be done very easily. You could probably have 2 people driving around Durham collecting samples for like 1 million. Okay, I'm exaggerating. 20 clinical trials if you did it efficiently.
Yeah.
Because I'm really tired of all the heart rate studies. And yet, you know, because it's not even being used. I love your idea about the withdrawal signs, but the bigger conceptual issue I'd like you to talk about is you made a really interesting comment about it being more difficult to deliver telemedicine with therapeutics that weren't rewarding, like the glutamate modifiers, because and you know the deep inner circle of that is that they like the other medications better. And I was torn between saying, well, maybe we should be listening to them, and maybe we're letting them continue in behaviors that really aren't all that helpful. So what do you think about that dichotomy? Because I could see it both ways.
Yeah,
you know more about patients than I do, so I want to hear what you think.
Well, I mean, we are talking about new medications, new mechanisms. So if we want to push that, we have to make an effort on that. I think it is important to sort of insist on some levels on non-rewarding treatments, non-rewarding medications, as long as we accept a personal choice in the treatment, in the study as well, of that non-rewarding medication. There are timing that have to be respected in the sort of natural history of drug addiction, that patients are not ready to be delivered on that treatment, and we should listen to them. So more than going for always agonist treatment, let's listen to them. I agree with you. And many more times than you think, than I think, patients is willing to try something in alternative. You know, we have reached the level of saturation with buprenorphine, for instance, after 25 years, which is reasonable because that's what medications do. And we are ready for some other alternative treatments.
Okay, well, thank you. We're getting right on to 1 o'clock. I'm sorry we didn't have more time to discuss, but that was a great presentation. I enjoyed it. And hopefully, if people want to discuss things further, maybe they can email
Sure,
you.
sure.
And
no problem.
So
thank you for the opportunity.
Yeah, thanks. And I want to remind people, February 22nd, TRI plus CABC Symposium on Marijuana, Brain Science and Community Impact, Risk Prevention Legalization. Please go to the DIBS website, the CABC page for registration for that. And thank you again, and have a great day.
Thank you. Bye-bye.